can read the title. So I'm pretty excited about the talk. So Will, please.
Great. Thanks for the introduction, Barry, and it's a pleasure to be talking at Rounds today. Just a little bit of housekeeping. I won't be looking at the chat box while I talk, but if questions come up that want immediate answers, Barry, please feel free to interrupt and you can mention what's in the chat box. Also, you'll see in the chat box right now a poll everywhere address. This is one that you can just type into your phones, and you can pull up poll questions that will come up later. It'll be prompted again later on those slides. So before I get into the meat of my talk, maybe a bit about who I am and how I got here. I'm one of the relatively newer staff in the infectious disease group at St. Paul's and at UBC. And I come in kind of a roundabout way from Vancouver, then away and back. And so when I look at my professional trajectory, it was, started up in northern British Columbia, and actually up there working with Dr. Abu Hamor during my training in the Northern Medical Program was some of my first interest in tuberculosis when we reviewed hospitalizations, primarily amongst the Indigenous and First Nations individuals in northern British Columbia. I did my core training over in Alberta at the University of Calgary, both internal medicine and infectious diseases, and took opportunity during that time to do some international electives, working in South Africa specifically to get more clinical experience, not only with tuberculosis, but drug-resistant tuberculosis. I also had the pleasure of spending time down in Colombia, in both Medellin and Bogota, and Tijuana, again, working in clinical tuberculosis settings. After my core training, I went to Atlanta, where I was at the Rawlings School of Public Health, and a focus of my master's in public health thesis down there was looking at a large outbreak in the inner city of Atlanta, and specifically looking at patient experiences and how patient experience in the homeless shelter system there influenced their seeking care. I also had the pleasure of spending time in Florida working with their Center for AIDS Research and their tuberculosis group there. And that all brought me back to Vancouver, where now I split my time between St. Paul's Hospital, Vancouver General Hospital, and the BC CDC, with a focus on general infectious diseases and additionally in tuberculosis. When I'm not working, one of my favorite things to do is go sea kayaking, and this was my most recent trip this past summer off the northern coast around Bella Bella. And one of my favorite things to do while sea kayaking is beachcombing, and this is the holy grail of beachcombing for anyone that's also has this passion, finding glass balls or the buoys that were used to be used that wash up on beaches. And I'll come back to this. I was thinking about this talk on my last kayaking trip. A few disclosures before I get into my talk. Mycobacterium tuberculosis is my favorite microbe, and so I have a bias and a particular passion in this, and I see tuberculosis everywhere. I think depending on what specialty you're in, you tend to see your illnesses with a lens of your practice, and so I kind of think everything is TB when I first have a look at it. I am primarily a clinician, and some of what I'm talking about today is going to be the diagnostic side, and I work closely with excellent colleagues in the laboratory, both at St. Paul's and at BC CDC. And so I'll be thinking about this mainly through the lens of a clinician. And I'm also one of the co-authors of a section of the extrapulmonary disease in the upcoming revised tuberculosis standards. And some of what I've talked about today will be a sneak peek at what's going to be coming in the new standards, hopefully in the new year. Here's my broad general objectives for today. I had to revise the talk as I thought it's hard to talk about anything now without couching it in the current pandemic situation, particularly as we're starting to see case numbers rise again. I really wanted today's talk to be practical and relevant to a broad range of individuals in internal medicine. And so I'll be focusing on primarily the diagnostic side of things. Tuberculosis treatment in Canada is largely centralized, as is true for low incidence countries around the world. And it's primarily housed in the public health infrastructure here in British Columbia at the BC CDC. But the workup of suspected tuberculosis is something that is decentralized. And depending on your practice pattern, you may or may not infrequently or frequently encounter tuberculosis. And I hope today's talk touches on that. As well, the current standards for tuberculosis care in Canada are almost a decade old, and they'll be revised in the upcoming year. And so some has changed since 2013, and I'll be trying to focus on some of those evolving or emerging areas, specifically in reference to extrapulmonary disease. When we talk about tuberculosis, a quick reminder of the tremendous burden that this infection and associated disease has globally. The most recent reports from the World Health Organization released earlier this month in the 2020 report outline this in stark numbers. So the estimates globally are that about a fifth to a quarter of the world's population is infected with tuberculosis. So latent tuberculosis infection or tuberculosis infections are the terms I'll use. And that's almost 2 billion individuals. That manifests in disease. This is the active illness of tuberculosis in about 10 million people in 2019 alone, and resulting in about 1.7 million deaths. This makes it the #1 infectious disease cause of mortality globally, and has been for several years now. We look at trends around the world, you'll see that the global tuberculosis incidence is declining thanks to more readily accessible therapeutics and enhanced public health measures. This 20-year graph here from the World Health Organization, the shaded area on the top bar is uncertainty. And you can see that that's narrowing as the black line on the bottom is showing that our identification and reporting of new cases is improving. So our estimates are improving as well. And that hashed line on the middle and bottom are the current NTB targets set out by the World Health Organization. And so the current 2030 NTB target would be a 90% reduction in TB incidence. And we're still a ways off from that, but moving in the right direction. If we zoom in on Canada and look at a longer timeline, you can see the impressive history of tuberculosis control in Canada over the past nearly 100 years here. You see that back in the 1920s, where mortality was high, then came along the introduction of BCG vaccination in the 20s that continued fairly widespread in Canada up until the 70s. You also see here the incidence rate, the solid bar, climbing up until the 50s and then beginning to see a decline. And this dovetails with the introduction of not only enhanced public health measures for control, but most notably pharmacotherapy. Starting initially in the 1940s when Waxman and Schatz discovered streptomycin, followed by subsequent agents. And you can see a brief timeline of the highlights of pharmacotherapy here. The most recent national data that the Public Health Agency of Canada has released is for 2017. There's been some delay on the updates given current diversion of public health staff for the coronavirus. But you can see in 2016 and 17 here, a snapshot of the national distribution of tuberculosis. Within 2017, about 1,800 cases and a highly variable incidence rate depending on what part of the country you're in, with the highest incidence rates in Nunavut at 265 per 100,000. And in 2017, no reported cases in Prince Edward Island. British Columbia has the highest incident rate, and it's tied with Alberta for this in 2017, with more, or a higher incidence rate, I should say, than Ontario and Quebec. When you break down who's getting tuberculosis in Canada, the vast majority are individuals that are foreign-born, typically coming from TB endemic parts of the world. As well, within Canada, there is a disproportionate burden in our Canadian-born Indigenous population. But the epidemiology of tuberculosis is now shadowed, at least nationally and internationally, by the coronavirus. And I think it's important to put these pandemics in perspective. And so using the most recent WHO data from the 2020 TB report, as well as the most recent, or I should say, things are changing quickly. So as of October 21st, when I looked at the Johns Hopkins University Center for System Sciences and Engineering tracking tool, this is how I would compare head-to-head these two different pandemics. First of all, the year of 2000 for tuberculosis, we saw about 1.7 billion deaths, and so far, or so 1.7 billion infected, I should say. And again, that's the latent form of tuberculosis, whereas the best estimates were around 40 million or so infected with coronavirus, although there will be some underestimates there. The Canada-specific infection burden is estimated at a little over 200,000 cases. In terms of active disease, roughly 10 million each for these in 2019. And in Canada, at present, that's global data, about 35,000 active cases when I looked. And the death burden, the death toll between these two in 2019 globally is quite stark, with over 1 million for both, slightly higher for tuberculosis. And you can see the Canadian breakdown here. And this is where the biggest difference between these occur, whereas the global burden of tuberculosis is outside of Canada. In Canada, the death rate or death count from COVID-19 is substantially higher. We're really comparing apples and oranges here, though. You know, bacterial versus viral illness, the relative burden in Canada, a disease from antiquity, tuberculosis, and a much more acute or novel disease in COVID-19. The impact of coronavirus is quite stark on the global tuberculosis pandemic. And this is something that I think was very clearly highlighted in the newest global tuberculosis report. Taking data from India, which has the highest absolute burden of tuberculosis globally, accounting for about 25% of total tuberculosis cases. You can see here the effects of a lockdown that occurred there back in March. That's the vertical hashed line on the graph on the left. And after the lockdown, you see a substantial drop in the reporting of tuberculosis cases. If you track this forward, although there's been some recovery in the reporting of cases over the subsequent months, there's still been approximately a 40% reduction. And based on modeling, if you translate this into excess deaths associated with underidentified cases of tuberculosis at a 6-month period with a decrease in 40% of detection, you're looking at over 1 million deaths associated with this. Those would be the curvilinear lines on the graph to the right. Looking at history as well, we have a previous comparator for the impact of tuberculosis control by pandemics. You can see the graph here from the United States highlighting between 1978 and 1998, whereas in the decades leading up to the 1980s, we'd seen steady declines, and public health was even claiming potential elimination of tuberculosis in the United States. There was again a steady uptick in the early 80s, and this coincided with the HIV pandemic. HIV globally remains a major contributor to ongoing tuberculosis control challenge, and it is the #1 opportunistic, tuberculosis is the #1 opportunistic infection amongst individuals with HIV causing mortality. To understand how one pandemic influences another, and particularly thinking about the overlap between COVID-19 and tuberculosis, it's important to understand the social determinants of health and how these influence risk of disease acquisition and outcomes once infected and ill. We're beginning to quantify just how this looks with COVID-19 in terms of the social determinants of health and outcomes. But for tuberculosis, this is well established in the Canadian population. We know that individuals experiencing homelessness are at 14 times greater risk of TB. indigenous-born Canadians are 4.5 times more likely to have TB, and foreign-born individuals that often have a greater burden from the social determinants of health are at increased risk as well. And COVID-19 will likely amplify these for individuals already at risk of tuberculosis. You've probably seen this graph, or some of you have. I think this is a nice depiction of the ripple effects of COVID-19, and that there will be multiple waves, not only of infection, but of the consequences. And each of these subsequent waves will have different impacts on tuberculosis illness and control. So pivoting from that epidemiology now, I'm going to tie this to a case as we discuss a bit about the specifics around diagnosis and management of extrapulmonary tuberculosis. And so it's opportune that Barry is presenting or has introduced me, as I'll be discussing a case that he and I wrestled with over the past several years. And so this was a 72-year-old Asian male from Hong Kong who was being followed for fever of unknown origin. His history presenting illness was over 5 years and characterized by relapsing and increasing fevers quite high, with temperatures over 40 degrees. And these fevers were often coincided with right lower quadrant abdominal pain. He had hematochezia and anemia. You can see the rest of his profile here, notable for a history of chronic hepatitis B infection, for which he was on antiviral therapy, and he'd had previous ablations for hepatocellular carcinoma. By the time I got involved, I was the 9th physician in this individual's care. He'd had 4 internists working on him, 3 of my colleagues in infectious diseases, and a surgeon. All of their hard work is highlighted here in terms of what was found. Really an outstanding question between malignancy, inflammatory bowel disease, and potential infection, including tuberculosis. The imaging on this individual had really localized to the terminal ileum, as well as some mesenteric adenopathy. The infectious disease histories were most notable for his country of origin, being Hong Kong, with time spent in Taiwan, and he worked as an engineer. From a tuberculosis specifics perspective, he had exposure. I believe it was his brother at age 16 that had tuberculosis. He was offered latent tuberculosis therapy, but never received it. He was BCG vaccinated in his home country, and his workup had demonstrated that he was HIV negative and had steadily controlled hepatitis B on lamivudine therapy when I saw him. Surgical interventions trying to identify the pathology here included 4 endoscopies, as well as a capsule study, all of which identified fluctuant terminal ileal disease that had been apparently progressive up until when I saw him, with nearly a little over 20 centimeters of disease characterized by multiple deep ulcers in the terminal ileum. He'd also undergone laparoscopy, and the laparoscopy had shown considerable inflammation in the abdomen. This is an individual that did have multiple previous surgeries, and that may have been contributing. Pathology from the biopsies of the endoscopies, as well as the biopsy at time of laparoscopy from a lymph node, were all obtained, and none of them confirmed granulomas were present, nor any organism. So the question that was posed to me was, can I say if this is extrapulmonary tuberculosis or not? I'll highlight kind of the key factors that go into my decision about this here. And most notably were the 3 tuberculosis specific tests that we had. He had a positive tuberculin skin test. He'd undergone an interferon gamma release assay, and I'll talk more about these if you're not familiar with them in a second. And his was identified as positive or reactive. And the tissue samples so far had all been culture as well as molecular diagnostic test negative, and I'll elaborate on molecular diagnostics shortly. So this is where I'd like to get some audience participation. I think this should automatically become an active poll. And if you go to listed at the top of the screen there, the pollev.com with WConnors364 on your whatever device you're on, internet or your phone, you can enter selection, or you can text the number listed there. I'll give people a second. The first question, I'll ask 4 questions here is, well, first of all, should tuberculin skin test and interferon gamma release assays be routinely used in the diagnosis of extrapulmonary disease? As votes come in here, it's kind of a Gallup race where you can see, and hopefully this isn't influencing people's choice too much. It is anonymous, so I'm curious. Okay, so there is division amongst the group about whether they play an important role here. About 1/3 saying yes, 2/3 saying no. And everybody here knows what an IGRA is, apparently. Okay, so whether they should be routinely used or not is one question, but the more practical question is, would you have done it in this case? And so I'm curious what people would have done, just because evidence supports one thing. Our practice patterns don't always correlate with the evidence. So it looks like the majority of individuals would have ordered this test, a little bit higher than those that felt that they should be routinely used in the diagnosis of extrapulmonary disease. The next question I have is, should nucleic acid amplification tests, these are specifically PCR-based or genetic material-based tests for tuberculosis, be routinely used in the diagnosis of extrapulmonary disease, so used on extrapulmonary samples? And I'm seeing a similar split as for the IGRA question here, around 2/3 saying they should and 1/3 not. So this gives me a sense that there's certainly room for discussion here. And then the final question I have is around treatment duration, another common question that comes up. So compared with pulmonary tuberculosis, should extrapulmonary tuberculosis routinely be treated with extended course anti-tuberculous therapy? And by this, I mean 9 or more months of therapy. We'll talk about what routine refers to in that part of the talk. Yeah, and this highlights how centralized care is. As you can see here, a number of individuals are deferring to tuberculosis services, which is often the case as they are followed throughout treatment if they're in the community. Okay, well, excellent. That gives me a baseline and also shows the audience kind of where uncertainty exists. So as I jump into the discussion about extrapulmonary tuberculosis, first a quick review of the biologic stages of tuberculosis. And so models that we have and epidemiologic data suggest that, you know, the vast majority of people that are exposed actually don't go on to infection. The original studies looking at infectious cases, so individuals that are smear positive as an index, and how many of their close contacts over a period of time would become infected, and using a marker here being immunologic tests like a tuberculin skin test, or when these studies were done, tuberculin skin test, or a quantiferon or IGRA test, suggested that between 10 and 15 secondary infections would occur over a year in smear positive index cases. Those individuals that go on to latent infection, thought to be about 30% after exposure, then go on to one of 2 subsequent potential stages: lifetime latency, which would be the vast majority, or individuals that develop disease. And specifically amongst individuals that develop disease, there are 2 major forms: earlier primary disease, which will be the dissemination of tuberculosis from early lack of immunologic control, or late reactivation disease, which in a healthy host, about 5% will have early primary disease. And this is early onset, typically in the first year after exposure, to late reactivation, which would be outside of that initial exposure period. And here the lifetime risk of reactivation is about 10%, but front loaded to those first 2 years. Again, this refers to in good health. Individuals with immunocompromise would be at increased risk of early and late disease. We tend to think about tuberculosis primarily in the lungs, and extrapulmonary disease is an area of active basic science research in terms of how disease disseminates and in whom. This is really, simply put, a balance between host and microbe. So host health factors, including immune function that may be related to primary immune defects or secondary disease-associated defects, can influence this. And then microbial virulence is another area of research, with different strains of tuberculosis potentially being more virulent or more evasive of the immune system. It comes down to, at an immune response level, really a dynamic immune response centralized around the formation of granulomas. Granulomas are the body's attempt to wall off tuberculosis, and in doing so leads to a period of control, or the latent stage, where the non-replication of tuberculosis may be occurring, and then subsequent opportunism, really, where the bacteria can, again, take the upper hand. This may be influenced by aging, illness, or iatrogenesis, as I list here. And different conditions will undermine the immune control of tuberculosis, the highest risk being HIV or more advanced disease specifically. There's a 100-fold increased risk compared to individuals without risk factors for reactivation. And that would be characterized as about 10% per year risk in untreated HIV, developing an active disease after infection. The spectrum of risk for developing reactivation disease and dissemination certainly increases, or certainly is influenced by other conditions, most notably chronic kidney disease, diabetes, and as immunosuppressive therapies. And the spread beyond the lungs is really one of lymphohematogenous spread, with, depending on the degree of immune control, the extent of spread. And this can occur both in the primary infection stage prior to established immune response, or later in established infection when there's reactivation and immune evasion. The epidemiology of extrapulmonary tuberculosis is quite limited. However, when we look at areas that have relatively good population data and reporting, we get a sense that there's around 20% of tuberculosis will have an extrapulmonary component. And that's true in Canada as well, with personal communications from PHAC in their upcoming report that in 2018, about 23% of tuberculosis cases in Canada were extrapulmonary. Interestingly, we're seeing an increased trend in extrapulmonary disease, with the 10-year average being about 13%. The last several years, we've seen increased proportion. When we look at the sites of extrapulmonary disease, I've listed the top 6 here. The vast majority are lymphatic disease, and I'm referring to peripheral lymph node disease, not visceral or intrathoracic lymph node disease here. And this tends to manifest as cervical or supraclavicular disease. As well, you can see the other less common forms listed here, with MSK being your bone and joint disease, occurring about the same frequency as CNS disease at between 2% per year of reported cases in Canada. About between 5 and 20%, depending on which data sets you look at, are concurrent disease with pulmonary and extrapulmonary disease apparent after workup. The primary risk factors that have been identified from the Canadian data continue to be female individuals, younger age, and foreign born. This is true when looking at other low incidence settings as well. I didn't have trend data from Canada, but the US data, somewhat dated now, gives a similar sense to the trends in extrapulmonary disease. So data here from the United States between 1993 and 2006, comparing pulmonary disease, which is the white bars, and white dots, with extrapulmonary disease, which are the black bars and black squares, show you that the overall incidence in active tuberculosis has been declining, most notably amongst pulmonary disease, whereas the proportion of extrapulmonary disease has remained relatively stable and increasing. The reasons for this are not entirely clear. There certainly is a contribution of more chronic comorbid conditions, as well as the increased use of immunomodulatory and immunosuppressive therapies and organ transplantation. This trend has been seen also in other low incidence settings in Scandinavia at population level data. I was curious to know a little bit more about what's happening in our backyard, and Mark Romney and our lab at St. Paul's helped me briefly review some data of cases at St. Paul's and Mount St. Joseph's that were diagnosed through the St. Paul's microbiology lab between September of 2018 and 2019. And from that, there was 42 individual cases identified, with 33 being pulmonary disease and 9 being extrapulmonary disease. I wasn't able to calculate the overlap between the two, so some of the extrapulmonary may have been concurrent pulmonary disease. It's interesting to think that over this 1-year period, 42 cases at the British Columbia, we're seeing between 200 and 250 cases per year. And so that would be representing nearly 20% of our province's TB cases. Again, some of these cases are not necessarily hospitalized cases, but will be reflecting individuals that underwent testing that went through the St. Paul's lab. Many of these are bronchoscopy samples that were collected by MSJ and St. Paul's bronchoscopy suite. So on that background of epidemiology of extrapulmonary disease, I wanted to spend some time specifically focusing on diagnostics, as this will be what most of you are faced with when it comes to working up these cases of query extrapulmonary tuberculosis. And I break down diagnostics into the old and the new. When we look at the old, these are the tried and true tests of microscopy and histopathology, and the culture-based tests using mycobacteria-specific media, which is the gold standard. Extrapulmonary samples tend to have low sensitivity for acid-fast staining, given the posibacillary nature of infections outside the lungs, and they have lower sensitivity on histopathologic examination as well compared to pulmonary samples. The culture remains the gold standard, but requires a specialized laboratory, and this is still essential for drug susceptibility testing. The primary limitation here is delay in diagnostic results, being 2 to 6 weeks of incubation typically for growth of Mycobacterium tuberculosis. In terms of more details about the testing characteristics of these two, I list here in broad strokes, fluid is a less useful sample compared with tissue, and the organ site involved means highly variable outcomes, with pleural fluid and pleural tissue having some of the lowest yield on microscopy and histopathology, whereas lymph nodes and urine tend to have much higher yield. When we look at culture as well, similar trends are present. You can see the breakdown by sensitivity here. Pleural fluid and ascites being low sensitivity compared with substantially higher sensitivity of culture in urine, and lymphatic tissue having the highest culture yield amongst extrapulmonary sites. That was the old, and much of that data comes from well-established case series and reports around previous diagnostic tests that were used. When I talk about the new, or I should say newer, the focus here will really be on molecular diagnostics, and specifically I'm talking about polymerase chain reaction or nucleic acid amplification tests. And I will be focusing on a specific proprietary platform called Expert MTB RIF. And that's because this is the most widely used globally and studied platform for molecular diagnostics for which we have the most evidence. The importance of these tools are that they have a rapid turnaround and they're highly specific. They've also have the ability not only of identifying the genetic material of Mycobacterium tuberculosis, but additional genetic targets such as resistance genes, so they can give more information. That's true particularly of the expert MTB-RIF platform that I'll discuss. These do, for extrapulmonary disease, require invasive sampling, and these remain as an off-label test at most places. And as such, many laboratories have in-house developed nucleic acid amplification tests that they use for extrapulmonary samples. It's important to remember that these tests do not determine viability. I recently had a case that is 8 years out from treatment of tuberculosis and still has a positive molecular diagnostic. And so remember that these are not for evaluating treatment response, but rather for diagnosis. And these tests tend to be more expensive depending on the platform used, as well as purchasing. I think when I was talking to the lab, they're estimating between $5 and $100 specifically for the expert MTB-RIF platform. In terms of indirect tests, I'll be talking about these immunologic tests, specifically the interferon gamma release assays. Another indirect test for tuberculosis would be a tuberculin skin test. These are minimally invasive. That's their advantage over molecular tests for extrapulmonary disease, but they lack specificity. And expense here needs to be thought about both in the actual test itself, but the laboratory time and the clinical time when it comes to doing tests like tuberculin skin tests that require multiple visits for injection and reading. So starting with the indirect tuberculosis diagnostics, we primarily have used these for the diagnosis of latent tuberculosis or tuberculosis infection, and that's what they're best studied for. The goal here was to identify people pre-disease with infection so as to identify people that would benefit from chemoprophylaxis or infection treatment to prevent the development of disease. Tuberculin skin tests, or the purified protein derivative test, is a skin-based test that looks at delayed hypersensitivity reaction, and there is a considerable practitioner variation here. And one of the primary limitations here is BCG vaccination, which still remains common in many parts of the world where tuberculosis is endemic, will potentially influence this, mainly in the earlier decades of life. We interpret this based on a risk-based approach and measurement with greater than 5 or 10 millimeters based on the host risk. And you can see the quoted sensitivity and specificity here for individuals without BCG vaccination. The major advancement in the field of indirect diagnostics were the advent of interferon gamma release assays. Two of the most commonly used ones are listed here. The abbreviations I use are QuantiFERON Gold in-tube test or the T-spot TB test. There are slight differences in these tests that I won't be focusing on today, but these tests are really looking at the BCG independent immune response to exposure to Mycobacterium tuberculosis complex. And they're uninfluenced, as stated, uninfluenced by BCG, but they only require a single visit and not a follow-up. And they are somewhat more objective results, although we'll talk about limitations there. The quoted meta-analysis sensitivity and specificity ranges are here for latent tuberculosis infection. In terms of how these IGRA tests work, these are in vitro tests of cell-mediated immune response. So they use whole blood and they quantify the release of interferon gamma. This is either concentration or quantification of the producing cells of interferon gamma. This is detected specifically in response to an antigenic protein from Mycobacterium tuberculosis. These antigens are not present in, not influenced by BCG, and the specific proteins here are the early secreted antigen target, or ESAT6, as well as the culture filtrate protein 10. Historically, another protein, TB7.7, was in earlier generations of the QuantiFERON test. The results of these are qualitative or semi-quantitative, but really the interpretation is one of qualitative reactive or non-reactive, and is looking really for a threshold of interferon gamma concentration, and they're read as positive or negative. And this can be quantified as well with the number of cells or spots using the T-spot test. And there's a threefold interpretation of positive, negative, or borderline when using the T-spot test. When it comes to using interferon gamma release assays for tuberculosis disease, the major dilemma is differentiation of infection versus disease. Individuals with infection are at risk of disease, and if you are suspecting disease, the probability is that they've already had exposure. Limitations are abound with these tests, and it's important to realize that there is considerable pre-analytic and analytic variability. A nice summary by Pai et al. In 2014 is what I took this diagram from, but the number of steps involved in these fairly complicated tests introduce different pre-analytic and analytic variation that can influence test results. Everything from the time of day the test is collected to the time between delivery to the lab, incubation in the lab, which tends to be extended incubation over 12 hours, can lead to high variance. And so for the quantiferon in-tube test, this is quoted as being about 10% variance test over test. Host immune response is quite dynamic as well, and there has to be some interpretation in light of this for these results being about a 10% discordance of repeat tests. So individuals that have one test and a follow-up test, 1 in 10 will show a change in their outcome from either a positive to a negative or a negative to a positive. That's been quoted for the quantiferon in-tube test. It also is influenced by the disease site and or burden of disease. And the studies around different sites of active disease have shown that there is correlation between increased positivity with gastrointestinal, MSK, and lymphatic disease compared with pleural and central nervous system disease. And this makes sense to me with the amount of immune tissue located in the guts and your lymph nodes, that you would have a more robust immunologic response that we're measuring here. In terms of the application of these tests for diagnosis of extrapulmonary tuberculosis, meta-analysis data that's somewhat dated now shows specifically for the quantiferon gold in-tube test here in individuals with active tuberculosis. This is a composite of both pulmonary and extrapulmonary disease. You can see the pooled sensitivity here is quoted at 0.8 or 80%. That would leave you with 1 in 5 false negative test. When you look at specifically individuals with extrapulmonary tuberculosis, now a mix of sites involved, a meta-analysis reported in 2012 showed even lower sensitivity, quoting about 72% sensitivity, and here we're seeing about 1 in 4 false negative tests. Now, this data I present from these two meta-analyses are primarily from the use of quantiferon gold in-tube, but looking at the other forms of IGRA tests, there is similar variation. More recently, there has been a development of what is being quoted to be a better interferon gamma release assay, and this is the quantiferon plus test. This now reflects the most commonly used lab-based test in British Columbia, and is the replacement test for the previous quantiferon test done through the BC CDC. The improved sensitivity of this test relates to the use of modified antigens, as well as the use of additional testing for CD8 cell response. Whereas traditional IGRA tests used CD4 cell response, CD8 lymphocytes are thought to potentially be more active or responsive in terms of interferon gamma release in early infection, individuals with tuberculous disease, or those most likely to progress. Also, there's been some discussion around the potential interpretation of the CD8 to CD4 ratio in terms of treatment response. I put question marks next to all of these because there are at present only limited data to support this, and these are areas of uncertainty. The sensitivity of this test overall for latent and active extrapulmonary disease is quoted to be higher, but there's a lack of data right now for their use in extrapulmonary disease. Here is one of the available studies in pulmonary tuberculosis using this new IGRA release assay, and this shows really, as stated in those meta-analyses, positive individuals occurring in whether HIV infected or uninfected in about 80% of individuals was the sensitivity they found in this study. In terms of results, this is what you'll see at the bedside when you order these tests. So this is a report from our provincial lab of the result for the QuantiFERON Plus test. And you can see here that they have reported out the tube 1 and tube 2, which is the CD4 and CD8 tubes. And this test here was a test that I did on a patient with this chest CT scan a couple of months ago here at VGH. And this is the result that I had ultimately. So was a negative IGRO test and a 4+ heavy burden of pulmonary disease. And it again highlights, on a single case basis, the limitations of this test. This individual did have uncontrolled diabetes, and there have been reports of uncontrolled diabetes potentially limiting the sensitivity of IGRA tests. Moving on now, I wanted to briefly discuss molecular diagnostics, and specifically their role in extrapulmonary tuberculosis. And so the recommendations in this area have been evolving. You can see the quote here from our standards in 2013, and that there was inadequate or incompletely defined role for these. Subsequently, the World Health Organization, based on data from the Expert MTB RIF platform, began to recommend that these should be used specifically for diseases where rapid diagnosis was sought, that being central nervous system disease or TB meningitis. And these were further strengthened in their subsequent updated report endorsing the newer platform Expert MTB RIF Ultra, and I'll talk about that shortly. United Kingdom and North American guidelines have also included nucleic acid amplification tests as a conditional recommendation, or they suggest that they should be done rather than not done for extrapulmonary disease, although evidence for their use remains quite low. I wanted to specifically talk about molecular diagnostics for extrapulmonary tuberculosis with reference to the Expert MTB RIF platform, as there's the most data for this. This identifies genetic material of the Mycobacterium complex species, and also has the added benefit of detecting resistance mutations. You can see the schematic here from a publication in the New England Journal in 2010, showing the ease of sampling, minimal processing, and largely automated system. The cartridges are in a platform used for other molecular testing. Again, highlighted, it does not have the ability to determine viability, and it's a rapid and objective test with quoted 99% specificity on pulmonary samples. Turnaround time is quite quick, 1 to 2 hours. This has a high sensitivity individuals from sputum. If acid-fast bacilli positive, sensitivity is quoted for 98%, whereas for individuals that are smear negative or no acid-fast bacilli in sputum samples, sensitivity drops to 73%. The MTB RIF platform has been upgraded similar to IGRA Plus. This is now from standard to ultra. And the changes in these platforms has been an increase in the number of targets that are being probed for, as well as additional methods for detecting resistance. The breakdown and comparing the two are outlined in the table here. The level of detection is significantly lower in terms of colony forming units, as outlined at the bottom. Turnaround time is faster. And what they're using now is they're using a melting curve approach to identify resistance rather than multi-probe approach. And I had to read a bit more about what melting melting curve resistance testing is. And this is the idea that with heating up of the genetic material, sites of mutations will dissociate and then be linked with fluorescent tag faster or earlier than sites where there is no mutation, shown here in a graph. The MTB RIF Ultra platform is available at St. Paul's Hospital and now is globally beginning to replace the MTB RIF platform. MTB RIF standard platform is used throughout Fraser Health on unconcentrated specimens. This is a somewhat crowded table. I don't want to go through the details with you, but I wanted to show that there is emerging data here looking at specifically the use of this platform as the most studied molecular platform for extrapulmonary disease. And this is data that will be in the updated TB standards. What I show you here is the sensitivity and specificity comparing the two platforms with point estimates reflecting either single study were highlighted or meta-analysis data, as well as I lost my train of thought there, as well as the range estimates being from single studies here. There is a variable site sensitivity, but when we look at specifically sites like bone and joint disease, as well as genital urinary disease, you see particularly high sensitivity. We continue to see the low sensitivity when we look at sites such as pleural tuberculosis, as we've seen with limitations in acid-fast staining, as well as culture results at that site. So after that whirlwind of diagnostics, we get back to the case that I was mentioning. And in this individual, the question comes up, what do you treat? In this individual, at the time, there was competing diagnostics suggesting either at least latent tuberculosis and at most potentially active disease. And in between, the competing diagnosis of inflammatory bowel disease, the treatment of which may potentially awaken latent TB and cause active TB. So I have the picture here suggesting where I felt I was. This individual had taken 5 years to reach this point of making a decision. And I wondered, is this particularly unique? There is some research out there looking at delays in diagnosis for extrapulmonary tuberculosis. And these are both individual and health system factors in high incidence settings, such as Egypt and India, where healthcare provider awareness may be higher for tuberculosis. Individuals see an extended period delay between diagnosis over half a year in an Egyptian series, and with 3/4 of individuals in India with extrapulmonary disease in one health region seeking multiple health providers before reaching a diagnosis on average in the healthcare system for multiple months. In low incidence settings such as Scandinavia and Portugal, and similar to what we would see in Canada in terms of tuberculosis incidence, it takes about 2 times longer for these individuals to reach diagnosis. This is based on a systematic review in these settings. The very last point I'll make, and I'll move through this quite quickly to get to some questions if they're there, is around how long do we treat? And so standard therapy for pulmonary tuberculosis, assuming drug susceptibility, and these individuals don't have cavitary disease, they would be treated with a 6-month course of 4-drug therapy, pyrazidamide for the first 2 months, and ethambutol until drug susceptibility is known. Whether this is appropriate for extrapulmonary tuberculosis or not has been a question of much debate. However, it probably is, and there's evolving evidence, which is really now competing with dogmatic experts in this area. The potential benefit versus harm of over or under treatment underpins some of the ongoing discrepancies between evidence and recommendations. I summarize here for you where the evidence is at. The highest quality evidence supports standard or 6-month therapy for superficial lymph node disease with multiple clinical trials supporting this. Individuals with abdominal disease, there's been no evidence from several randomized controlled trials that more than 6 months is required with regards to reduce relapse. Musculoskeletal disease, we see that there's less than 2% relapse rate with 6-month therapy, and extending out to beyond 12 months of therapy does not significantly reduce that. That is from observational level data. And for pericardial disease, a mixture of observational data and expert opinion would suggest 6 months. The outlier remains central nervous system disease, whereas the available evidence from a recent Cochrane systematic review does suggest that compared with 6 months, greater than 6 months is not shown to have greater benefit. Yet expert recommendations in Europe and North America advise between 9 and 12 months. And this is really a balance between pharmacology and risk. The pharmacology piece here is that the standard drugs for treating tuberculosis have variable penetration. Most notably, rifampin will only penetrate the central nervous system at about 20% of systemic levels. And the concern here is that undertreating or shorter therapy will lead to highly morbid or mortal disease progression. So when it comes to the case that I was involved in as an example to tie this all together, ultimately, I couldn't make a final decision whether he had latent disease or active disease, and embarked on empiric therapy given the other diagnostics were negative. He had a transient response, however, persistent changes on repeat endoscopy. After completing 6 months of active therapy, he went on steroids and developed improvement, but with tapering, relapse, and was placed on a monoclonal antibody that binds the integrin receptor to prevent or to treat inflammatory bowel disease, specifically Crohn's, called vezolizumab. And he's been in relative remission since, with resolution of his abdominal pain and improvement in his anemia. So the ultimate diagnosis here, after all of this discussion about tuberculosis, I suspect this individual had Crohn's disease and at most latent tuberculosis. Going all the way back to the start of my talk, I'm always looking for the glass balls. I think the reality is that you get lots of different fragments. The tests that we have only give you little pieces of the puzzle. And often when you put all the pieces together, you may not have a glass ball. These are the pieces I found on my last trip, and I think it was actually a bottle, not a glass ball. Take-home points that I wanted to leave you with here. Tuberculosis is a major global health issue, and certainly COVID-19 is likely to worsen this. Extrapulmonary disease in low incidence setting is on the rise, and something that we have to be on the lookout for. The diagnosis of extrapulmonary disease is challenging, and gold standard remains cultures, but I would argue, based on what I presented today, that molecular tests are quite important. The diagnosis of these cases and management is a team sport. You have to rely heavily on your colleagues that do your invasive procedures, as well as the clinical expertise of your organ-specific specialists, including gastroenterology in the case I presented, and microbiology and pathology specialists are indispensable and often are the ones that can help you navigate the appropriate testing. For the use of IGRA tests and molecular diagnostics for TB, specifically active disease, I would encourage direct conversation with the microbiologist to guide whether it is appropriate in your setting. IGRA tests, my bottom line is they're very easy to order. They're quite hard to interpret, specifically in active disease. I'm not sure that they add anything, and I'd be open for more discussion about this. And the evidence for treating tuberculosis is evolving and slowly becoming more evidence-based. Remember who your friends are and feel free to call them. There is the tuberculosis consult within the RACE app, and we do have the unit over at Vancouver General Hospital where I am today, a 12-bed inpatient unit. I conclude with, I always like this slide. This was a major success in the tuberculosis control era with the closing of the Trudeau Sanatoria in New York. This was in 1954, felt to be the end of tuberculosis in one major chapter closing with Larry Doyle, who was one of the last residents there, a former baseball player with tuberculosis, walking away. When the end will be, I don't know. So I conclude, I get to work with an excellent group of colleagues, all of whom have various expertise and are quite knowledgeable in tuberculosis as well. And I'd be open to any questions.
Thank you. Thanks, Will. Questions for Dr. Connors? Any questions for Dr. Connors? If not, I will tell you that I was one of the people that saw the patient that he presented, and my first thought several years ago when I saw him was that he had TB, and this was the diagnosis, and at that time we didn't confirm the diagnosis. And then subsequently, after it was all the ups and downs of this case, Will became part of the solution, not part of the problem that I had created. And you heard the results of that. And in the end, he was never as persuaded as I was, and I was wrong in the at the beginning, and I was wrong at the end. So thanks, Will, for all the help. Any other comments or questions for Dr. Connors? If not, I'll just remind you that next week's Grand Round is going to be at Vancouver General Hospital. Dr. Jason Andrade, who's one of the electrophysiologists, is going to be presenting, and I'm assuming that's going to be part of the discussion. Thanks, Will. Great talk.
Thanks, Barry. I see a few questions in the chat box here.
Please take them.
I'm just looking at, so one here is from Jen Grant. Does the increased proportion of extrapulmonary disease represent the type of patients who are likely to manifest it? And absolutely. The jury is still out on exactly why we're seeing increased extrapulmonary disease in low incidence setting, but major contributors are going to be the increased use of immunomodulator medicines, as well as organ transplantation has been proposed. Globally, HIV is the primary contributor to extrapulmonary disease, but the proportion of pulmonary and extrapulmonary disease has not been substantially changed. It's just that they're at risk for both. And so it is likely to be advances in the management of other diseases that have led to increased extrapulmonary disease. And amongst children in low incidence setting, our extrapulmonary disease is reduced. And so it's mainly amongst our foreign-born elderly individuals who get more comorbid burden that are reactivating. And then Dr. Parfit, she asked, she's curious about the gene expert in an 8-year, this is a case that was thoroughly treated and is now being monitored with residual inflammatory lesions in the abdomen. And so that's the one that had gene expert 8 years later, but has not grown from multiple resampling, so.
Will, I'm sort of curious about your guy. I mean, you've come to the conclusion that he had inflammatory bowel disease. It's an odd thing to get in your late 60s, early 70s. And did we ever get a biopsy of that tissue for culture or any other means to try and truly prove that that's what this was?
Yeah, great question. And that was really what triggered Barry and the gastroenterologist to say, wait, it's odd for a guy to be presenting in with his ethnicity and his age with inflammatory bowel disease. And that's why TB was suspected early on. He had lots of biopsies. And to be clear, those endoscopies included biopsies. There was never formed granulomas, and the molecular testing on stool as well as the tissue of the bowel was negative. However, sampling error is something that has to be considered. And ultimately, in order to progress with steroids and immune modulation for his inflammatory bowel disease, decided to treat tuberculosis. I think the fact that he ultimately promptly relapsed after finishing tuberculosis therapy supports that probably wasn't the primary driver. Interestingly, and another whole discussion is he did have substantial improvement while on anti-tuberculous therapy. And there is another area of literature around the role of anti-tuberculous therapy in modulating the immune response in inflammatory bowel disease. And so I think he got transient benefit, not because there was tuberculosis, but because of its effect on the microbiome. And that's been well studied as well.
You know, I just want to respond to that because I followed this man and I thought, you know, when we gave him a trial of anti-tuberculous therapy and he got better, he didn't get a little bit better, he got better.
Absolutely.
Back to normal. And I thought this makes the diagnosis. So what Will has told you now about the modulation with the inflammatory bowel disease with anti-tuberculous therapy is something I didn't know. Well, there's many things I don't know, but that's certainly one of them. And he was a demonstration of that fact.
Yeah, it's one of my longtime teachers' pet theory is that there's another mycobacterium causing inflammatory bowel disease that we just aren't able to detect.
Yeah, Mycobacterium paratuberculosis has been postulated to play a role here. And we have local researchers doing basic science research on this as well, and it's an area of active interest.
Good. Thank you very much for your questions, your participation, and certainly that wonderful presentation.
Please send any cases of tuberculosis my way. My email's here. If you want any supporting data or literature from my talk today, please reach out. Thanks again, really a pleasure.